Thank you, everyone. My name's Kelly, so you just had a Kelly, and it's another Kelly. I'm a research fellow from the University of Leeds, and my background's a bit different. I studied psychology, so I'm talking a lot more about decision making, and what I'll be talking about in particular today is a study I did in my PhD looking at the barriers to prescribing amongst GPs. So, okay, yeah, it's working, great. So, background, we already know this. Aspirin can reduce the risk of bowel cancer in people with Lynch syndrome, so for example the CAP2 trial, and that has led to policy changes. So the UK Cancer Genetics Group has guidance in this area where they recommend those in genetics discuss the pros and cons of aspirin with the patient, and then the GP prescribes, and then they have different doses of aspirin depending on weight. And we've also talked quite a lot today about NICE. So NICE is a government organisation that does guidance for NHS in England and Wales. And they also released guidance in 2020 to consider daily aspirin to reduce the risk of bowel cancer in people with Lynch syndrome. But it can be a difficult decision for people to make. You've got to consider both the benefit of potential bowel cancer prevention against potential harm. So aspirin can increase the risk of things like stomach ulcers and internal bleeding. It's more rare cases, but it's something to consider. But it's also something that healthcare professionals and GPs also have to consider in their decision making. So yeah, I did a previous study in this area. So thank you to anyone who took part, because it was advertised through Lynch Syndrome UK. And I interviewed people with Lynch syndrome and healthcare professionals, including GPs, to get what their thoughts were on taking aspirin for bowel cancer prevention and on this NICE guidance. And so yeah, I interviewed 15 people with Lynch syndrome who use or did not use aspirin. And I also, interviewed healthcare professionals, 23 healthcare professionals, including 9 general practitioners. And some of the key findings from this study were that I've got a scan me there. It's just like you can scan for the paper if you want to read it. All the papers I'm going to be mentioning are open access, so anyone can read them. But a key finding from the study among healthcare professionals was that generally healthcare professionals agreed that GPs should prescribe aspirin for patients with Lynch syndrome, including GPs, they also agreed. But GPs are unfamiliar with prescribing daily aspirin at quite higher doses, so they're more used to 75 milligrams daily, which is what people use for heart disease prevention. So they weren't quite used to prescribing daily aspirin at these higher doses, such as 150 or 300. And they also weren't used to prescribing it for bowel cancer prevention. So the big thing that GPs really wanted was more information and support from specialist hospital doctors. I've mentioned genetics and bowel cancer specialists. Actually, to be honest, they were more likely off the top of their heads to say that they wanted to talk to patients like oncology team or a bowel cancer specialist. Genetics tended to be lower on the list. They tend to think, oh, I don't really usually contact genetics, so maybe, but I'm not sure. But they wanted more information a lot of the time before they would be willing to prescribe. So this is what we tested in the final study of my PhD, was sort of to test this, to understand if providing that additional information that GPs wanted, if it did actually influence their willingness to prescribe. So we did a massive online survey where we did it to investigate further GPs' willingness to prescribe aspirin for bowel cancer in Lynch syndrome. So we recruited 672 GPs in England and Wales to an online survey. So I only recruited them from England and Wales just because the NICE guidance, which is going to come up in a second, that's for guidance in England and Wales. So just restricted the sample to those countries. And yeah, it's a massive sample, which we managed to recruit nicely using a market research company. So all the GPs went onto this online survey, and all the GPs provided with really basic information such that daily aspirin is often used to prevent bowel cancer in Lynch syndrome, and just briefly what Lynch syndrome is. But what we sort of manipulated was that GPs had an equal chance of being allocated, i.e. randomised, to one of 8 different information sheets. So the main thing we were trying to look at is, depending on the information sheets or what the information they provided with, if that was influencing their hypothetical willingness to prescribe aspirin for a hypothetical patient with Lynch syndrome. So something they were all told, so across all the information sheets, all GPs were presented with this hypothetical scenario where a clinical geneticist has recommended them, the GP, to prescribe daily aspirin to a patient with Lynch syndrome. And some other information they were provided with as well was that the dose is usually around 150 to 300 milligrams daily. That aspirin is prescribed off-label for bowel cancer prevention. And that was quite standard information that they all got. As I mentioned, there was 8 different information sheets GPs could be allocated to. And across these information sheets, GPs could be shown or not shown the following 3 types of information. So as I mentioned, there's a nice guidance that came out in 2020. And as I talked about, I did interviews with GPs trying to get words out. I did an interview with GPs, and they typically felt that nice guidance was really important to them. When I was speaking to them, they felt that they were willing and comfortable to prescribe because there was nice guidance recommending it. Another information that GPs could be shown or not shown was the results from the CAP2 trial, with 600 milligrams daily being found to reduce the risk of bowel cancer and Lynch syndrome. And there was information from a patient decision support tool, which compared the harms of aspirin versus the benefits. And this presented the information such that for every 100 people with Lynch syndrome who take aspirin, 7 get bowel cancer. For every 100 people with Lynch syndrome who don't take aspirin, 13 get bowel cancer. And then the harms were presented in a similar way to sort of show that bruising more easily and things is quite a common side effect, but the other side effects are a lot more rare. So it might be a bit confusing. As I mentioned, we had 8 information sheets, but there was 3 types of information. It's because we were trying to see which type of information influenced GPs' willingness to prescribe and which combination of information together. So this looks really confusing, but I'll break it down. Those were the 8 types of information sheets GPs could be allocated to. So for example, if they were allocated to information sheet 1, as I mentioned, all GPs were told to prescribe aspirin for this patient. And if they were allocated to the first information sheet, they saw that there was nice guidance, they saw the CAP2 trial results, and they saw that risk-benefit information. If they went to information sheet 6, they just saw the CAP2 trial results, they didn't see the additional information. GPs allocated to information sheet 8, they didn't get any of this additional information, they just got told that the clinical geneticist wanted them to prescribe it. So the exciting part, what did we find? Maybe less exciting actually. We found that highlighting the nice guidance, the trial evidence, and that benefits and harms information, it didn't increase or change GPs' willingness to prescribe. Reassuringly though, most GPs were willing to prescribe, about 80% of the sample, but that does mean a fifth were unwilling. So we also investigated in the survey other reasons that might have been influencing their decision that they could sort of tick and say, yeah, this influenced my decision to be willing to prescribe. And we found that 9 in 10 GPs who were unwilling were concerned about the harms of aspirin still, regardless of whether they were shown information on the benefits or information comparing the benefits and harms. That was still quite a big concern. 4 in 5 were concerned about prescribing aspirin off-label for bowel cancer prevention. So off-label means that aspirin is not licensed for bowel cancer prevention, but this is quite common in primary care for off-label medication because It's quite a long and expensive process for drug companies to license medication for other uses. But it does mean that prescribing off-label carries as heavy a responsibility for GPs than fully licensed medication. So that was a barrier to some. In an open text box in the survey, we also asked GPs if there was additional information that influenced their decision. So they could just write anything else that was influencing their decision. And 16 of the GPs who are unwilling to prescribe thought actually the clinical geneticist should prescribe, that it shouldn't be up to the GP. And 10 felt that patients should not be going to them at all, they should go to their pharmacy. They should go straight from clinical geneticist to the pharmacy. And the thing with this is, it is really cheap from the pharmacy, but at the end of the day, it's really important that the GP does sort of know that you're on aspirin and prescribes it, because the GP is important because they can see your medical records, they can check that aspirin's suitable for you, and they can have that on your medical records. Then that could be important in the future for them to know that you're on aspirin. And then also clinical geneticists don't often have experience prescribing. That's why it is asked for the GP to prescribe. Another scam me for this paper if anyone wants to read it, but I'm also happy to email anyone these papers. So we also found that less than half of GPs were aware of aspirin for bowel cancer prevention in Lynch syndrome, and just over 17% of GPs were aware of this new NICE guidance. So to conclude, we really felt that there was need for more targeted information to support the prescribing of aspirin among unwilling GPs, such as we've mentioned the fact that there are concerns still, I guess, about the harms and prescribing off-label, and potentially that they don't feel it's their responsibility, and having a real clear strategy that is coordinated with primary care so people understand what people's roles are in this pathway. And also, just to clarify, I'm not saying don't provide this information to GPs, because everyone is different, and as Kelly mentioned earlier, people are individuals. So one GP wasn't willing to prescribe, but in an open text box at the end said, I would have been willing to prescribe if I knew there was NICE guidance. So just, it is individual. Just briefly to mention, so I finished my PhD, and now I'm a research fellow looking to develop very early stages behavioural trials to support weight reduction in Lynch syndrome. So yeah, thank you to listening. Thank you to everyone who is involved with this study, and especially thank you to Lynch Syndrome UK and everyone who took part in the research. Lynch Syndrome UK did amazing work to advertise the interview study, so I really couldn't have done it without them. Yeah, thank you so much.